Pneumonia is an infection and subsequent inflammation of the lung tissue, and especially a particular part of the lung tissue, the alveoli, where gas exchange takes place. So in pneumonia, we really have both an infection and, due to the infection, impairment of respiratory function. Because pneumonia starts as an infection and generates respiratory dysfunction, it really has manifests itself with two kind of separate categories of signs and symptoms. On the one hand, you have those that are directly related to the fact that it's an infection. On the other hand, you have those that are pulmonary or respiratory in nature. So let's talk about some of the signs and symptoms that manifest due to the infectious nature of pneumonia. Well, like most infections, you have a high fever, you have aches, body aches, muscular aches, sometimes called myalgia. You have cold, clammy skin, and you also are likely to have shivering or rigor. Shivering. So all of these you'll see with pneumonia, just like you'd see with most other types of infectious processes. However, what makes pneumonia more unique are some of the pulmonary compromise that goes on. And the way that this typically manifests itself in pneumonia is you have rapid breathing, tachypnea, you have difficulty breathing, dyspnea, and the difficulty breathing often leads to decreased oxygen, increased carbon dioxide retention in your blood, and these two conditions will lead to some of the other manifestations that we see. Also, with pneumonia, you have a lot of coughing and a lot of secretions. So you'll see that you'll see and hear a lot of junk in the patient's lungs. That is a result of the pathophysiology of pneumonia. So due to the decreased oxygen, you'll also have cyanosis, especially in more advanced cases of pneumonia. Cyanosis is blue tint or hue around the mucous membranes, and this is sometimes visible in lips, the nose, the ends of the fingertips. It's typically more visible in children than in adults. Patients with pneumonia, because of what's going on with all this secretions and inflammation in the lung, will have a particular type of chest pain that's pleuritic. That just means that it's worse when they breathe in. And because of the decreased oxygen and increased CO2, people with advanced pneumonia will also have changes in mental status, in mentation. So this could be anything from agitation to sedation to the patient just being unresponsive. So how is pneumonia diagnosed? Well, the gold standard for pneumonia diagnosis is the chest x-ray. So it's a simple test that can be done at the bedside, and what we see on chest x-ray that indicates pneumonia are infiltrates and consolidations. So both of these just mean that on the x-ray, the clinician's able to see a collection of fluid and other products in the lungs that wouldn't be there in a healthy lung. Some of the other tests and exams that we can do to diagnose pneumonia, the sputum culture, and this is not only important for diagnosing out pneumonia, but also for finding what the causative organism is. So with the sputum culture, we can either ask the patient to expectorate into a culture container, or the patient can be suctioned down into their trachea by a respiratory therapist or by the nurse, and we can get a sample that way. That's often sent off to the lab, to microbiology, where it's put on a petri dish and grown out and see what organism it is. And the identification of this organism is important because it can guide our antibiotic therapy as we move into later stages of treatment. And we'll talk about that in the treatment section a little bit. Other labs that can be helpful are the complete blood count. And what we typically would see in a complete blood count, we see an increase in white blood cells, so called WBCs. White blood cells just indicating there's an infectious and immune response taking place. Also, an ABG is often drawn. An ABG can be a good indicator of respiratory efficiency and respiratory status. And on the ABG, it's an arterial blood gas. So we're looking at the concentration of gases, especially oxygen and carbon dioxide, in arterial blood. And things that we would see with any kind of respiratory distress and with pneumonia, we'd see a decrease in O2 and eventually an increase in CO2. Both of these would indicate that respiratory effort is insufficient. So what I'd like to briefly discuss here is how we can work to prevent pneumonia. First of all, we'll talk about general patients. This would be the patient out in the community or on your medical surgical floor. Patient. And then we'll talk a little bit about a kind of more specialized topic, but one that's a hot topic in nursing currently, and how to prevent pneumonia in the ventilated patient, and specifically how to prevent what's called VAP, ventilator-associated pneumonia. So first of all, just general prevention of pneumonia, like any other infectious process, the best way to prevent it is good hygiene, and this especially is, talking about hand hygiene, washing hands, being very diligent about washing your hands every interaction with your patient. And every person going into that room, seeing the patient, or entering that house, seeing that patient should be washing their hands before and after patient contact. And then the second category, as far as preventing pneumonia in the general population, be immune support. So like any type of infection, one of the best ways to prevent it is to keep a good, strong immune system. We can do this with nutrition and with hydration and activity. So with your typical medical surgical patient, you'll see an effort to really to start normal nutritional and hydration habits as early as possible, and also to do kind of progressive mobility with that patient. Starting off right after surgery, having them do turns, cough and deep breathe, and things like just sitting at the edge of the bed, dangling, then moving on to out of bed to chair, and then on to just walking through the unit, things like that. And doing that as early and as aggressively as possible on these medical surgical patients, especially after a surgery, is really going to help prevent pneumonia in patients that could otherwise be susceptible to it. In the ventilated patient, you really have a situation where the patient is extremely susceptible to pneumonia due to the fact that they're often sedated, so they're not coughing, they're less likely to move, they're going to have a lot of other comorbidities. There's a reason why they're ventilated. They may be diabetic, they may have any other type of immunosuppression. They also have this artificial airway that's going from their outside environment down through their oropharynx into their airways that provides this nice little route for microorganisms to follow and latch on to create an infection. So with these patients, there's what we call bundles. All bundles are a kind of group set of practices that need to be followed to prevent pneumonia, and in this case, ventilator-associated pneumonia. So first of all, again, it's hygiene, just like the other one. Hygiene here is going to be not only rigorous hand hygiene, but also hygiene related to the tubes of the ventilator circuit and the ventilator machine itself. Also, the head of bed needs to be elevated. This helps prevent aspiration of secretions into the lungs, and that carries down microorganisms. Along the same lines, oral care, this might go with hygiene as well, helps decrease the burden, the microbial burden in the oropharynx of the patient, just decreasing the number of microbes that could follow that tube down into the lungs. Frequent suctioning, both of the mouth and the subglottic area, to also make an environment that's less likely to produce microorganisms. So if you have a wet, moist environment, all these secretions just sitting there in stasis, microorganisms love that type of environment. They can reproduce very well there. So suctioning above, higher up in the airway, in the mouth, down into the subglottic area will reduce that situation. Also, finally, what you really want to do is try to wake. So that might mean decreasing sedation and extubate your patient ASAP. Because once you get that tube out, you've really got rid of the whole situation that puts the patient at risk for ventilator-associated pneumonia.